Hello everyone, Medical Level Up here. We're back again with another video. Today's video is going to be approach to diagnosis, and we're going to be talking about headaches. And specifically, we're going to be talking about secondary headaches. Let's get started. Before we define primary and secondary headaches, let's bring up the lazy board. Now, the first thing you need to know is that primary headaches happen because of the intrinsic brain pathology. Secondary headaches happen because of some sort of vascular problem, meningeal problem, or an infection somewhere. So it is a structural abnormality. The first thing we're going to be talking about is subarachnoid hemorrhage. Now, the history findings are that the patient can present with altered mental status, a sudden onset headache. The location of the headache can be occipital in region. One of the things that I like to do when I'm taking a history is I ask a leading question from the patient is that how many seconds did it take from the start of the headache to the peak intensity of the headache? If it was only a couple of seconds, it is actually an abrupt onset headache. But if the patient says that the headache took like around a couple of hours or a day to reach maximum intensity, it is less likely to be a subarachnoid hemorrhage. When you come to the examination in subarachnoid hemorrhage, you have to always look inside the eyes of the patient using an ophthalmoscope. Remember that SAH plus preretinal hemorrhages is known as Terson syndrome. Of course, you will also look for signs of meningeal irritation, nuchal rigidity, Brudzinski sign, and Kernick sign as part of the examination. Don't forget to do cranial nerve examination because cranial nerve neuropathies can help you locate the aneurysm in the brain. An example would be Horner syndrome presentation that is usually because of posterior communicating artery aneurysm. The first thing you need to do in order to investigate a subarachnoid bleed is to do a plain CT head. The sensitivity of a plain CT head approaches 99 to 100% when done within the first 6 hours. False positives can happen when a patient is very anemic or the hematocrit is less than 0.30. The second thing is doing a lumbar puncture. You have to look for xanthochromia in the cerebrospinal fluid. Xanthochromia can be detected by two measures. One is the visual method, and the second one is the spectrophotometric method. In the visual method, you just have to centrifuge the CSF, look at the supernatant, and compare it to a white color. The third thing you need to do after an LP is a CT angiogram. You don't want to go straight to a CT angiogram before you do an LP because 2 to 3% of the population is walking around with asymptomatic aneurysms, and you do not want to treat those. The second differential is an intracerebral hemorrhage. Now, it is as important as subarachnoid bleed because it carries high mortality and high morbidity. The history is going to be that of a headache, repeated episodes of vomiting. The risk factors in a history that you have to ask about are whether the patient was receiving any tissue plasminogen activator for an ischemic stroke, or whether the person was on warfarin or not. When you examine the patient, you will definitely find some degree of monoparesis, hemiparesis, cranial neuropathies. If the blood has extended into the ventricular system of the brain, you are sure to find some signs of meningeal irritation, neck stiffness, nuchal rigidity, Brudzinski sign. Now, the next differential we're going to talk about is one that you've been hearing since medical school quite a bit. You have a patient that comes in with altered mental status, fever, headache, and a stiff neck. What is the first thing that comes to your mind? Meningitis. Make note that not all the patients will have all of these symptoms. Most patients will have 2 out of the 4 symptoms that I just mentioned. The other symptoms or examination findings that you can have are monoparesis, hemiparesis, nuchal rigidity, Kernick sign, Brudzinski sign, cranial nerve neuropathies. And of course, you can also have a rash, which can range anywhere from a peteke to a purpura. There is another examination that you can perform on a patient, which is jolt accentuation of the headache. You can ask the patient to look side to side and rotate their head horizontally, and if it accentuates or increases their headache, it has a somewhat positive likelihood ratio for a bacterial meningitis. Again, the investigations of choice are going to be a plain CT head first, and followed by a lumbar puncture. Now, the function of the plain CT head is not really to diagnose meningitis, but you have to rule out other causes as well. The second thing is that when you're performing an LP, you have to make sure that there is no condition inside the brain that is going to cause herniation once you perform the lumbar puncture. I'm going to leave a table up on the screen which will show you the CSF findings of bacterial meningitis, viral meningitis, tuberculous meningitis, and so on and so forth. Now, the next differential is venous sinus thrombosis. 89% of patients will present with a headache. but they will have some risk factors for venous sinus thrombosis to occur in the first place. Pregnancy, hormone replacement therapy, combined oral contraceptives, or some degree of thrombophilias. Remember that women are more predisposed to this condition as compared to men. There are 3 separate syndromes that happen with venous sinus thrombosis. The first one is an encephalopathic syndrome. The second one is isolated intracranial hypertension. And the third one is focal neurologic deficits or seizure, or both of these together. Remember that the most common focal neurologic deficit is monoparesis or hemiparesis. The examination findings in this condition can lead you towards where the thrombosis actually is. If there is chemosis, proptosis, orbital pain, and subconjunctival injection, you're looking at cavernous sinus thrombosis. If there is pulsatile tinnitus, you are looking at jugular vein thrombosis. If there is isolated hypertension syndrome, you're looking at a isolated lateral sinus thrombosis. If you're looking at seizures or a focal neurologic deficit, this is most likely to be a sagittal sinus thrombosis. The next differential is one that not only presents with a headache but with neck pain as well. I'm talking about vertebral artery dissection. Trivial amount of trauma such as a roller coaster ride, turning left to see when you're backing out of the driveway, boxing, or a trip to the chiropractor where he manipulates the joints inside your neck can result in vertebral artery dissection. The presentation of vertebral artery dissection is going to be headache, neck pain. 12% of patients will present with Horner syndrome. Some people will have pulsatile tinnitus. You can even have stroke or TIA mimics, and you can have seizures as well. Some patients will even present with a Wallenberg syndrome, which is also known as a lateral medullary syndrome. You can test this condition by doing an MR angiography or a CT angiography. The next differential is giant cell arteritis. Now, this is a vasculitis that has a predisposition to the temporal artery. Remember that the incidence of GCA increases around age 50, it peaks at age 71, and it decreases back to normal at age 90. History of the patient is going to be headache, which can be pretty much anywhere over the head. He will have visual changes such as diplopia or amaurosis fugax. The patient will also complain of jaw claudication, which is what happens when you get pain when you're eating your food or chewing your food. This happens because of vascular insufficiency of the masseter and the temporalis muscle. Once you're examining the patient, make sure that you look for temporal artery tenderness and do check their visual acuity using a Snellen's chart. You can also check their visual field, which is going to be affected in this condition. In order to investigate giant cell arteritis, you need to do some biomarkers, which are CRP and ESR. If the CRP and ESR are raised, kudos. But if they're not, there is still a 4% chance that it is still giant cell arteritis. If the index of suspicion is high for this kind of condition, refer all of these patients to a temporal artery biopsy anyway. Now, this is a bit of a minefield, since temporal artery biopsy has a sensitivity which ranges between 50% to 95%. There is also another diagnosis, which is color Doppler ultrasound of the temporal artery, which you can do in order to strengthen your diagnosis. There is one more differential that affects the eye, which is acute angle closure glaucoma. The history will be very typical. A patient who is sitting in the dark watching his TV or something, he gets sudden onset pain in one side of his eye. When you examine this patient, he will have redness of the conjunctiva, a hazy cornea, and a fixed mid-position dilated pupil as well. The pain will be retroorbital, and he will have a headache with it as well. There are 2 more differentials that need to be diagnosed with a sense of urgency. The first one is carbon monoxide poisoning. This is very straightforward. It is mostly environmental. Multiple members of the same household or work are going to be associated together. When the patient leaves the area where the carbon monoxide is leaking, he will have symptom resolution as well. You can get a point of care venous gas, which will tell you the carboxyhemoglobin levels of the patient. The second differential is post-dural puncture headache. Now, this happens mostly in people who have had recently a lumbar puncture. 90% of patients will present within 12 hours of the lumbar puncture. Symptoms other than a headache are neck pain, lower back pain, vertigo, visual changes, neck stiffness, and auditory changes. The most important thing about a post-dural puncture headache is that there is a postural element to it. As soon as the patient sits up, the headaches tend to get worse. When the patient lies flat, the headaches tend to resolve. In the end, let's talk about some honorable mentions. If you have a patient who has had a positive travel history, he has an infectious picture such as myalgias, headache, fever, he has got a high white cell count, and you see specifically low platelets on his blood, think of dengue hemorrhagic fever and malaria, because these can also present with a headache as well. Temporal mandibular joint disease can also present with a headache as well. sinusitis, cervical strain can also present with a headache as well. It is also important to look for a postcoital headache as well. You have to work up postcoital headache in the same way as you do a subarachnoid bleed. The last thing in this video is that I want to give you 2 tools in order to help strengthen your diagnostic capabilities. The first one is a mnemonic by the name of Snoop. Now, any of these findings, if they are positive, you have to think of a secondary headache. Let's write it down. So S is for systemic signs or symptoms. N is for a neurologic deficit. O is for abrupt onset. The second O is for extremes of age less than 5 or age less than 65. This is usually said to be as older age. The first P is progression of headache syndrome. So if a patient tells you that this headache is very much different as compared to the usual headaches he gets, it is most likely a secondary headache. The second P is postural aggravation. The third P is papilledema, and the last P is pregnancy. The second tool I want to give you is the Ottawa SAH rule. There is a series of questions which is age more than 40, neck pain or stiffness, abrupt onset headache, headache onset during exertion. If any of the answers of these questions is yes, you cannot rule out subarachnoid hemorrhage, and appropriate workup needs to be done. That is all for today. I hope you liked this video on secondary headaches. The next video is going to be covering primary headaches. Have a good day.